Folks, I just wanted to let everyone know that this afternoon session will be recorded. I'm going to go through a couple of housekeeping items so that when individuals have questions, they can participate. Again, welcome to this, our session of the Fiscal Health from Systems to Sustainability webinar series on transitioning from ICD-9 to ICD-10 coding. Is your organization prepared? In the event that you are able to see the PowerPoint but do not hear audio, you should have received a prompt to have your system dial a phone number to connect you to audio. If not, this number here is the webinar call-in information as well as the event code in case you need to access this. As I stated, we will be taking questions and answers during the webinar and keeping them in a holding spot as everyone is been logged in on mute. During the webinar, if you do have a question, you can put it in the Q&A box, and I will keep the questions and moderate those at the end of the presentation. So first, I'd like to provide a little bit of background really quickly on the Fiscal Health Initiative. The Fiscal Health Systems to Sustainability program is designed to ensure the fiscal sustainability of Ryan White funded grantees. We have three modes of doing this. Each grant year, we do 3 regional trainings where we go into a site and provide 2-day regional training on topics of interest identified by the site and region in collaboration with the project officers and grantees. We also provide individualized technical assistance, and this can be done virtually and in person. And we also have an online learning component, which is what we are doing today in the webinar. This program is sponsored by HRSA-HAB and is administered by Health HIV. In order to participate and receive technical assistance from the Fiscal Health Cooperative Agreement, it's developed specifically for Ryan White grantees, Part A, Part B subgrantees, and Part C and Part D grantees and subgrantees as well. We have a number of resources that are available online. If you visit www.healthhiv.org, these are 2 examples. We also have several webinars that are archived. As I stated earlier, this webinar is being recorded and will be kept in our archive so that if any of your colleagues or you would like to view again, we will have that available online to you. Just wanted to let everyone know, and we will send these an announcement out tomorrow as well, that there is an upcoming webinar on Tuesday, June 22nd, 2015, on effective health insurance eligibility determination strategies. If you would have any additional questions regarding the program, or if you would like to request technical assistance on any of the topics related to Fiscal Health Initiative, feel free to send me an email at julio@healthhiv.org. I'm going to go ahead and turn the webinar over to our presenter, Stacey Murphy, and unmute her line. Stacey, would you like to begin by presenting a little bit of background on your experience as you lead into the webinar?
Okay, sure. So good afternoon. My name is Stacey Murphy, and I am a consultant at JMS Building Solutions. I possess over 30 years of practice management, physician credentialing, re-credentialing, contract management, coding and clinical documentation experience. I am a certified professional coder, and I'm dual certified. I have my CPC certification through the American Academy of Professional Coders, and I also possess my RHIA, which is a Registered Health Information Administrator through the American Health Information Management Association. I also am an ICD-10 CM and PCS approved trainer through AHIMA. And in addition to that, I also have a full-time job where I work as the Chief of Health Information Management Services, working for the Veterans Administration. I've been working in billing and coding for the greater part of 30-plus years, and I really enjoy providing education and coding topics to not only providers and physician groups, but I also teach billing and coding at 2 online colleges here in the New York metropolitan area. So I am really excited about doing the presentation today on ICD-10 implementation, and I hope that the information that you will receive today will be very resourceful in helping you to plan your ICD-10 agenda on implementation. I'll turn it back over to Julio really quickly, or would you like me to just go ahead and begin? Julio? Okay, I will begin the presentation. So let's see. I apologize, just give me 1 second. So today's topic is maximizing third-party reimbursement, looking ahead to ICD-10, which was the previous slide. Now, Julio, is the presentation here? I see the ICD-10 FAQs, but it looks like the presentation is not here. Okay, well, I'm going to ad-lib. So presently, what you have in front of you are the FAQs. What I did in preparation for the presentation is I put together some ICD-10 implementation tips, and so there are roughly 20 questions here on the slide deck that you can use to prepare your ICD-10 planning. And the next document is another document that provides you some resources that will allow you to go online to various reputable organizations such as AHIMA and the AAPC, as well as CMS. And you can access numerous documents that will assist you with your ICD-10 implementation plans that you should have already began, since we are moving forward with the ICD-10 implementation on October the 1st, 2015. And just as a side note, I wanted to take a couple of minutes to talk about 2 very important bills that are on the table in Congress. Presently on the floor, there is a bill that addresses ICD-10 that was introduced on April 30th, and then there was another bill that was introduced a couple of days later. The 2 bills that were introduced, the first one is the ICD-10 Act. That bill was introduced on May the 12th, and in a nutshell, the representatives were not necessarily looking for a delay, but basically wanted to get some type of confirmation that there would be some additional testing that would assist providers and suppliers and services with ensuring that their claims are not denied. So in terms of the ICD-10 process, what would happen is this bill the bill specifically was to request that ICD-9 codes as well as ICD-10 codes be allowed to submit on various claims. And so right now, the bill is on the floor. There hasn't really been any movement. The second bill that was introduced earlier in the year, which was actually a bill that had been introduced last year, was the Cutting Costly Codes Act of 2015. So this bill was actually introduced about 2 years ago, and the bill failed. But in a nutshell, this bill was calling for another delay of ICD-10. So as of right now, we don't think that there will be another delay. We're probably 99% sure that ICD-10 will be phased in on October the 1st, and all health plans, all providers, everyone will need to begin reporting the new codes on all claims. Okay, now let me just see if I can get I'm just trying to get to the PowerPoint portion of the slides. These are your FAQ documents. So again, this information is available for you. And
can you hear me?
I can hear you now.
Okay, the third tab in is your presentation.
Third tab?
Yes.
Okay. ICD-10 slides? Oh, okay, perfect. Okay, so that document that we were looking at was the ICD-10 FAQs, and then there's another document that has resources. Again, these items are very resourceful in helping providers and facilities to plan for their ICD-10 implementation. So now let's get into our presentation. Okay. Now it seems like
the fourth tab that says Fiscal Health starts off Fiscal Health. That's your presentation.
Okay. So we are at the presentation, but apparently it looks like I'm not able to advance the slide. Okay, there we go. So our learning outcomes, I'll just do a basic overview of the ICD code changes.
Hi, Stacey, I'm sorry to interrupt. This is Jamila Mwakio. I just presented a question. For some reason, I'm not able to. Hi, how are you? Sorry to interrupt.
Okay.
I'm wondering if there is a way that I can receive the slides as well, because I'm looking at, okay, now it just changed. I was looking at the questions only, the frequent asked questions, but now I see the slides have come up.
Yes, yes.
At first,
right now we're on the learning.
Okay.
Right now we're on the learning outcomes page. Are you able to see that?
I can see it now. At first, it didn't show up. It just had the frequently asked questions.
Okay.
Thank you.
Okay. You're welcome. Looks like there's some technical difficulties out there. We will try our very best to resolve those if it's on our end. So again, the learning outcomes, we'll do a history of the ICD code changes. We'll do an overview of these changes, the impact of the code changes. So basically, we're already being impacted by these changes. We have providers that are currently still using ICD-9 and have not began the process of transitioning to the ICD-10 code set. And so, in short, you only have 5 months to go, and it's very important that we begin our initiatives to move forward with the ICD-10 implementation. I have some information about the ICD-9 phase-out as it relates to what our government has done in preparation for ICD-10. And then I have a few tips and some steps that you can follow to get you more involved with what you need to do in preparation for ICD-10. Okay, let's see. Now the technical difficulties are back on my end. Okay. I apologize. Looks like the slides are not advancing. Okay, there we go. So the next couple of slides just provide you some of the acronyms that will be used in the presentation. And let's see. my goodness. I'm using a touch screen. Oh, gosh. Julio, do you think it might be beneficial if you take over can you take over the slides when you're in, and then I'll just...
Yeah, just tell me when to advance.
You can advance now.
Okay.
Okay. So let's talk about the history of ICD, the International Classification of Diseases Coding System. It began with ICD-9. The acronym ICD10CM is on your slide for you. It stands for International Classification of Diseases, 9th Revision, Clinical Modification. It was developed by the World Health Organization in 1948. It has been revised numerous times here in the U.S. Since 1979. And in a nutshell, the ICD-9 code system has been used quite frequently for morbidity and mortality statistics. And over the years, the government made the decision to begin using it also for reimbursement purposes. The ICD-9 code system describes medical conditions, diseases, injuries, and poisons. In the ICD-9 code system, there are actually three volumes of that book, and the first two volumes address the diseases, and the last volume address the procedures that are coded by the hospitals. So we will not really spend a lot of time speaking about the procedure codes in ICD-9 because most of the people on the call are working in professional in doctor's offices and practices. And so you generally will be just using the medical condition volumes of the code books. Next slide, please. So CMS mandated the use of ICD-9 codes on all claims back in October of 1988. These codes have been mandated, and in terms of how the codes are used, in order for your claims to be reimbursed, you have to assign the code to the highest level of specificity, and it must be correct. As a result of the code system being in place for the past 30-plus years, the current code set no longer reflects emerging technology and made to move forward with implementation of ICD-10. Next slide, please. So ICD-10 was also adopted by the World Health Organization. It was adopted in 1994. Here in the U.S., it has undergone a multitude of revisions that have resulted in the decision to move forward with the implementation. These codes will also be mandated for use on all of your claims, and the government is also using these codes for morbidity and mortality tracking purposes. In terms of how we use the codes currently, most provider practices, hospitals, most of the entities that are submitting claims to the insurance companies and to CMS and to the local Medicaid state agencies are currently submitting claims electronically using a HIPAA electronic transaction. Your acronyms are back on pages 5 and 6. The acronym HIPAA stands for Health Insurance Portability and Accountability Act. And basically that's just a mandate that requires that any information, any data collection or reimbursement information that is being sent electronically must be sent in a secure format. Next slide, please. In terms of your ICD-10 implementation, in order for you to be ready to submit claims and ensure minimal issues with your electronic transactions, it is important that you remediate your softwares to ensure that you are using the most current version. And in order to support ICD-10 codes, the version that everyone is currently using is version 5010. Now, version 4010 was used through 2003, and a bill was passed in 2009 mandating the use of version 5010 for all covered entities. Now, there was a discretionary grace period that was in place back 3 years ago. That grace period is passed, and everyone that falls under the topic of covered entity must be using version 5010, and everyone must, in terms of your ICD-10 implementation, ensure that you are your version 5010 is in place in time for ICD-10 implementation. Next slide, please. In terms of version 5010, I put this slide together for those individuals that are not really familiar with what version 5010 is. Basically, in a nutshell, it involves administrative transactions that you submit electronically, such as patient eligibility, verification, claim submission, and your remittance advices, which are your EOBs. So any of that information that you send or receive electronically falls under version 10. And as a result of the code changes, the significant code changes that affect ICD-10, it was necessary to remediate and change over to version 5010 to support those codes. So again, all covered entities must change from version 4010. Exceptions, as of right now, are the state workmen's compensation carriers, long-term disability, short-term disability, and no-fault carriers. So those are the exceptions that at this time they're not mandated to remediate over to version 5010 or to remediate over to ICD-10, but because there is going to be a difficulty in trying to submit both claim types, most of these entities have already started to remediate over to version 5010 so that they too can also submit claims in the correct format. Next slide, please. So again, this is just a short list of some of those transactions that require the use of version 5010. So your patient eligibility, submit claims, check claim status, coordination of benefits. These are all of the various transactions. Well, actually, it's just a short list of the transactions that you will need to make sure that you're compliant with in terms of your implementation of ICD-10. Next slide, please. So now ICD10CM, just a point of reference, the ICD-9 coding system was divided into two separate code sets. It's ICD10CM and ICD10PCS. We'll spend a lot of time discussing ICD10CM because, again, most of the participants on the call are from providers' offices, insurance plans, and you will be using ICD10CM codes versus using ICD10PCS. So the ICD10CM, the acronym stands for International Classification of Diseases, 10th revision, clinical modification. So this is your diagnosis code set. It's very similar to the ICD-9 codes. The only distinction, as we will see in a few slides, is that the format of the codes is very different from the format of ICD-9 codes. Next slide, please. So this is the second code set under the ICD-10 system, International Classification of Diseases, 10th revision, procedure coding system. So this code set will only be used in inpatient hospital settings or institutional facility settings. So if you are currently in a practice, you would not be using these codes. You will continue to use the CPT codes. CPT stands for current procedural terminology. Most of the participants on the call would be very familiar with the CPT code system. You will still continue to use CPT codes, and the hospital facilities and institutional providers will begin using ICD-10 PCS along with ICD-10CM. The ICD-10 PCS is a brand new coding system, brand new code format, and this particular code set is taking a little longer for hospital facilities and other entities that will be utilizing this code system to learn it because it's a brand new code system. Next slide, please. Again, physicians and other entities that are currently providing health care to patients will continue using CPT codes and continue using HCPCS codes. The ICD10CM codes, you will begin using those on your claims effective October the 1st of this year. Next slide, please. So again, just a little bit of history. MCHS, the acronym stands for National Center for Healthcare Statistics. They're part of the CDC, and they are responsible for the ICD-9 code system. They'll also be responsible for the ICD-10 code system once we move to that platform. CMS will continue to maintain responsibility for the ICD-10 PCS code set. They are currently responsible for Volume 3, the procedure codes in the ICD-9 code system. So in terms of when the codes are updated, they're updated annually on October the 1st, and all of the revisions are on April 1st, every April 1st. Currently, there is an ICD-10 committee that is responsible for meeting twice per year to discuss code changes. So that committee will continue during the transition. They'll continue to meet twice a year. In fact, they just met in March. The next meeting is scheduled for September. So they have a 2-day meeting where they discuss a variety of code changes, determine whether or not the code should be implemented or deleted, or any code should be code title should be changed. Next slide, please. So this slide just gives you the timeline of the ICD-10 transition here in the United States. So the 2008 date reflects when the ICD-10 code set was proposed, and initially it was to be implemented on October the 1st, 2011. And if you just look at the timeline, you'll see that this code set has been pushed back numerous times, and we hope that on October the 1st of this year that we will move forward with the implementation. There has been a partial code freeze, and basically that just means that the committee, the ICD-10 committee, made the decision not to implement any new codes during this process where we are transitioning to the new code set. So there was a partial code freeze on October the 1st, 2011. There were some limited code updates that went into effect in 2012 on October the 1st. Limited codes went into effect on October the 1st, 2013. There was some limited code changes in October the 1st, 2014. In terms of the ICD-9 code system, there have been no updates at all to ICD-9. Most of the code updates have been in preparation for the ICD-10 implementation, which is basically 5 months away. Next slide, please. What has changed in ICD-10 versus ICD-9? There is new terminology and some revised terminology. There are new and revised coding guidelines. There is an increase in the number of available codes. Currently in ICD-9, there is roughly 1,000 codes, versus in ICD-10, there's approximately 90,000 codes. So there is a significant increase in the availability of the number of codes that will be used once we go live with ICD-10. There's increased use of specificity, increased use of laterality in the codes. So in ICD-9, in the code set, there is no designation of left versus right, but in the ICD-10 code system, there is an increased use of left versus right. And we'll see that, we'll see some of the codes. There's an increased use of combination codes. And so, for example, the code for diabetes is diabetes with neuropathy requires 2 codes, but in ICD-10, it will only require 1 code. So there's an increased use of combination code set in ICD-10 versus what's currently available in ICD-9. There's limited use of NEC and NOS. NEC stands for not elsewhere classified, and NOS stands for not otherwise specified, which just means unspecified. In ICD-10, there is 21 chapters in ICD-10CM versus in ICD-9, there's only 17 chapters. The PCS volume does not use eponyms as used in the ICD-9 volume, and as a result of the implementation from I-9 to I-10, there is room for expansion. And so again, ICD-9, because it's been around since for the past 30 years, there's no further room to add any codes, thus the reason for making the decision to phase it out and move forward with ICD-10. Next slide, please. So here's just a brief snapshot of what the new codes look like. And so again, in ICD-9, there are 17 chapters, and in ICD-10, you'll see that there are a total of 21 chapters. And this first slide provides you with a short description of the 2 new sections that are available in the ICD-10 code set. So if you look at where it says Chapter 7 and Chapter 8, diseases of the ear and adnexa and diseases of the ear and mastoid process were formerly a part of the nervous system code set in ICD-9. So the decision was made to make these 2 anatomic body systems their own section or their own chapter in ICD-10. Next slide, please. The same thing with the last 2 new sections. In ICD-9, there are 2 code types that are known as classification. You have your V codes, which most people are familiar with, and your E codes, which most people may not necessarily be familiar with. Those are used for injury and poison reporting purposes. So in ICD-10, the decision was made to make these a part of the main section as opposed to a supplementary classification, which is how it's currently set up in ICD-9. So Chapter 20 and 21 in ICD-9 comprise of the external causes of morbidity, which are your codes, and the V codes are currently transitioned to Z codes in ICD-10. So any of those diagnosis codes that you use for well visits, vaccines, those are now those will now be Z codes in ICD-10. Next slide, please. So some additional changes that affect the ICD-10 implementation. You'll find that there is a code expansion that, as a result of this code expansion, there are quite a few codes in ICD-10 that now have 7 characters, versus in ICD-9, the character value is it's only up to 5. So there's 3 to 5 characters in ICD-9 versus up to 6 to 7 characters in ICD-10. And the reason for the extra characters is to further describe and explain trimesters in the obstetrics. It also provides clarity on the diabetes classification, substance abuse, postoperative complications, injuries, and external cause of injuries. Next slide, please. Also in ICD-10, which is new versus ICD-9, the ICD-9 code set has an includes and an excludes, and the ICD-10 code set has an excludes 1 and an excludes 2. The excludes 1 functions as the excludes that's used in ICD-9, and the excludes 2 allows a coder to assign an additional code, which is a whole new concept that was not something that was used in ICD-9. Next slide, please. So here is a bit of comparative information for you to look side by side to see the differences in your ICD-9 versus your ICD-10. In volumes 1 and 2 of your diagnosis code set of ICD-9, there was approximately 13,000 codes. And on your ICD-10CM side, there's 70,000. The volume 3 codes were the 4,000 versus the 90, which we'll look at when we get at a later slide. Your ICD-9 codes is 3 to 5 characters in length versus up to 7 in ICD-10. And so if you look at the examples that I provide, 493.90 is the code for asthma in ICD-9, and J45.X is the code in ICD-10. V20.2 is the diagnosis code for a well visit for newborns, infants, and children, and in ICD-10, the code is Z00.121. So in terms of the new formatting of the codes, the look is different, but for the most part, the guidelines are pretty much the same. There are new guidelines, but they're pretty much, most of the guidelines are the same as what you're accustomed to in ICD-9. Also in ICD-10, the first character is always going to be an alphabet. The exception will be the letter U. The letter U is not used in ICD-10CM at all. It's not case sensitive. The ICD-9 code system does not have any distinction of left, right, or bilateral, and ICD-10 has quite a few left, right, and bilateral designation in its codes. There is, actually in ICD-9, there were a few codes that indicated initial or subsequent in the heart attack or the acute myocardial infarction section, and in ICD-10, there is an increased usage of initial versus subsequent. There were not many code combinations in ICD-9. There are a significant number of code combinations in ICD-10. And we established that ICD-10 uses the dummy placeholder X to allow for future code expansion. Let's, the next slide, please. So if you look at, again, here's the format. So ICD-9 on the left side of your slide, the code for an unspecified fracture of the ankle is 824.8, and there is only one code for that. But in ICD-9, if you'll notice, there is a total of 48 different codes in ICD-10. I provided for you just 3 of the codes just so that you could see the distinction. So the code for fracture of the right lower leg, which is an ankle, is classified to in ICD-10. The first code on the slide is S as in Sam 82.891A as in Apple. So as you can see, there are 3 different codes just for the ankle. So you got your right lower leg, which is the ankle, your left lower leg, and then this one is unspecified. So these are the 3 that I pulled so that you can see the distinction between the codes for the unspecified fracture of the ankle. And I just noticed that someone asked the question, what are eponyms? Eponyms are, it's like a pseudonym or like another name for. So for example, the one that I can think of off the top of my head is, oh gosh, now I can't think. As soon as I find an example, I'll come back to your question. But in the meantime, let's go to the next slide. So again, what I wanted to do is provide you some side-by-side comparisons of the codes. So in ICD-9, the codes for AIDS and HIV are on the left side of your slide. So 042 is what we currently use. And in ICD-10, we will begin using B20 for HIV and AIDS. You have your 079.52 and your 079.53. And again, on the right side of your slide, you'll see the cross map. So again, the ICD-9 code system currently is mostly numeric, and it has 2 sections that are alphanumeric. And when we convert to ICD-10, it's 100% alphanumeric. Next slide, please. So the next couple of slides just provide you some examples of the I-9 codes versus the I-10 codes. So again, HIV positive, the code for HIV positive in ICD-9 is V08, and in ICD-10 it's Z21. The code for HIV counseling in ICD-9 is V65.44. In ICD-10, it's Z71.7. Next slide, please. I wanted to also show you a comparison of the well-visit codes. So I provided the most commonly used well-visit diagnosis codes in ICD-9. If you'll notice, V20.2 is the code for routine infant, child, or adolescent checkup. And in ICD-10, you have 2 codes. Z00.121 is the code for encounter for routine child health exam with abnormal findings versus your Z00.129, encounter for routine child health exam without abnormal findings. So when we transition to ICD-10, if the physician finds any abnormalities during that visit, the appropriate code that would be used is Z00.121, versus if there are no abnormal findings during that encounter, then you would use Z00.129. And someone's asking questions, does the ICD-10 distinguish between HIV positive and CDC defined AIDS? So I'm sorry, why don't we go back to slide 25. Let's go back to 25. Okay, so if you notice on slide 25, V08 is HIV positive, and in ICD-10, it has its own code that means the same thing. Asymptomatic, which is HIV positive, and the code for that is Z21, Z as in zebra. And if you go back one more slide to number 24, HIV AIDS, which is different from HIV positive, the code is 042 in ICD-9. and in ICD-10 it's B20. Does that answer your question? All right, and so now let's go ahead to slide, we were on the well visit slide, so if we can just go back to the well, okay, thank you. The well visit code for an adult is V70.0, ICD-9, and so again, if you notice, there are two new codes in ICD-10. You have the encounter for general adult medical exam without abnormal findings, and then you have the encounter for general adult medical examination with abnormal findings. So if you'll notice, there is a significant increase in the number of available codes as we move to the ICD-10 code system. I think the previous question that someone asked about was eponyms. So an eponym example that I can provide is Keller-bunionectomy. So the Keller-bunionectomy is named, it's a procedure where they remove bunions, and it's named after someone famous whose name just happens to be Keller. And this use of eponyms will not be in existence once we transition to ICD-10. All right, next slide, please. So again, some more examples. In ICD-9, there are 39 different ICD-9 codes for vaccines, and the decision was made to map that backwards to just one ICD-10 code. All of the ICD-9 codes that we're commonly familiar with using in ICD-9, such as the flus, your MMRs, your tetanus, and your diphtheria, tetanus, and Asella pertussis, all of those codes have now mapped to one code in ICD-10, Z23. So in some cases, they've taken a code and exploded it out to 2 or more, and then in other cases, like the example here on this slide, they've taken a series of codes and backwards mapped it to just one code. And someone's asking, are there codes for lead poisoning, environmental inspections, and clearance? Off the top of my head, I don't have an answer for that, but I believe that there are codes for lead poisoning, and because there are so many more codes in ICD-10, there should be a code that you would be able to select that would describe the scenario that you posed here in your question. Next slide, please. The new coding system, and I'm not going to spend a lot of time on this because, again, this will only impact hospital facilities, institutional facilities. This new code system, your ICD10 PCS, will not be used by physician practices at all. So the new coding system, ICD10 PCS, next slide, please. Here's the comparison. So there's approximately 4,000 codes in Volume 3 of the ICD-9 code book versus the 87,000 in ICD-10. The ICD-10 Volume 3 codes are 3 to 4 digits, and they are numeric codes only. And in ICD-10, they are 7 alphanumeric characters, and they must have all 7 digits in order to be considered correct. Medical conditions are used in ICD-9, but they're not used in ICD-10. Frequent use of NEC and NOS in ICD-9, and they've limited the use of it in ICD-10. There is no distinction of laterality in ICD-9, and there is frequent use and distinction of laterality in ICD-10. The generic terms for body parts are used in ICD-9. Detailed descriptions are used for body parts in ICD-10. We just spoke about eponyms. They're commonly used in ICD-9, and they have minimized it, and in fact, they're trying to phase it out in ICD-10. There are general body locations in I-9 versus your detailed body locations in ICD-10. Frequent use of combination codes, and in ICD-10, combination codes are being used less frequently. The whole premise behind the change in ICD-10 is that there is a complete overhaul of new terminology in PCS to reflect the current wave of new technology that exists in healthcare. So in terms of the usage of the PCS code system, the facilities have to learn a whole new code set, but they also have to learn new terminology that goes along with that code set. Next slide, please. So this is what the code structure of ICD-10 PCS looks like. First character describes the section. The second character describes the body system. The third character describes the root operation. The fourth character is for the body part. The fifth character is for the approach. And the sixth character is the device. And the last character is a qualifier. In ICD-10 PCS, every code must have 7 characters in order for it to be considered correct. So again, we're not going to really spend a lot of time going over this portion of the ICD-10 code system because this doesn't really impact how your practices currently operate. Next slide, please. I'm not going to spend a lot of time here. So every code must have 7 characters. Each character represents an aspect of the procedure as seen on the previous slide. The first character represents the section. There are 16 sections in PCS. And each code or each character has a meaning or a value. Next slide, please. The potential number of code values in ICD-10 PCS is 34. It uses 24 out of the 26 letters of the alphabet. It uses all of the numbers in the numeric system. The 10 numbers 0 through 9. The letters that are used are A through H, J through N, T through Z. The use of O and I has been eliminated from PCS to prevent any confusion with the digits 0 and 1. Next 2 slides, please. Next one. So here is a snapshot of what the alphabetic index looks like in ICD-10 PCS. So again, cholangiogram, it's giving you, it's sending you to a reference to see plain radiography, and it also says see fluoroscopy. So again, in terms of the code structure in PCS, if you look down at cholecystoscopy, you'll notice that it has its complete 7 digits, 7 characters. So this is the format of the ICD-10 PCS code system. And I noticed that there is another question here, I apologize. It says we need to distinguish types of immunization for UDS purposes. How would these be segregated? Okay, so to answer that question, in order for you to distinguish the types of vaccines that you're using, your CPT code would help you to designate that. So as long as you're assigning the correct CPT code from your CPT coding book, you should be able to distinguish the various vaccines that you're using. Because each of the CPT codes have its own, each vaccine has its own unique CPT code. Some of them are based on the patient's age. Some of them are based on the route of administration. Some of them are based on whether it's a combo vax versus whether it's a schedule of 3-dose versus 4-dose. So if you're utilizing the correct CPT code, you will still be able to report the statistical information that you need to provide for your various reporting purposes. Next slide, please. In terms of PCS, here is a snapshot of the ICD10 PCS table. So again, the process would start in the alphabetic index, which was the prior slide. And once you've determined your 3-digit table that you're going to review, you would then turn to that table and begin the process of building your code. So again, inpatient coders, facility coders have their work cut out for them because this code system is much more complex than the ICD10CM code system. Next slide. So in PCS, in ICD-9 CM, the procedure code for a laparoscopic cholecystectomy is 51.23, and in ICD-10 PCS, the code for a laparoscopic cholecystectomy is 0, F as in Frank, T as in Tom, 44, Z as in zebra, Z as in zebra. And so again, if you are a provider that goes into the hospital to round on patients that are part of your practice and you have to perform a procedure, you would not be using either of these codes. You would still use the CPT code book, and you would look up the code for the laparoscopic cholecystectomy, and you would assign that code for your service, and the hospital would assign these codes for their service. All right. Next slide, please. So the impact. The ICD-10 impact, rather I should say the implementation of the transition to the ICD-10 code system greatly impacts the data that we submit. And in terms of the current code system that we're using, because ICD-10 is much more detailed, this information will allow you to submit data for statistical purposes. It also affords easier accessibility for all of those quality measures that may require specific detailed information. So in terms of ICD-10, it is very important that providers begin that process of accurately documenting the services that they're performing, and it has to be as specific as possible now because ICD-10 requires this level of detail to provide for laterality. Diabetes also. So in terms of laterality, when a procedure is performed or a patient comes in complaining of a problem that may affect the left arm or the right arm, it's important now that your documentation includes that so that the coder can select the most specific codes. I've been on quite a few calls with a lot of payers, and what I'm hearing through the grapevine is that because the ICD-10 code system is so much more specific and has so much more detail, that they are not going to be adjudicating and paying claims for unspecified codes. So in those instances where there is a code that very clearly details left versus right versus bilateral, if you're submitting an unspecified code, more than likely your claims will be denied. So you want to take the time to go through your most commonly used codes so that you can start to identify those unspecified codes that you're using and begin to train your providers on what the documentation needs are so that they can begin to use the level of detail in their documentation once we move to the ICD-10 code set. Next slide, please. So some additional information that may have an impact on how you document and how you code. Retinopathy severity has to be very, very detailed. The codes required the documentation to state mild versus moderate versus severe. The presence or absence of macular edema, if the patient has that. Blindness versus low vision status. And in terms of glaucoma staging, the documentation must clearly state whether it's mild versus moderate, severe, or indeterminate. So, and then also going back to blindness, there are two different definitions that are currently being used. You have the World Health Organization's definition versus our definition that we use. So again, if you want to be reimbursed, you have to make sure that the documentation is very detailed and that it's consistent with the needs of the payer so that your claims could be processed. Next slide, please. Another area of detail that's necessary is asthma severity. There is a use of the measurement scale for intermittent versus mild persistent versus moderate persistent and severe persistent. The Glasgow Coma scale also has some level of detail. Fractures and injuries have now been further detailed in ICD-10, and we looked at some of the well-visit codes. So these are going to be areas where you will need to do an assessment of your provider documentation and begin that process of training your providers to make sure that they are well-versed in the documentation that is necessary to ensure that your coders are selecting the most appropriate codes. Next slide, please. So again, just to reiterate the impact and the significance and the importance of coding, if the provider doesn't document the most accurate information in the patient's medical record, it makes it a little difficult. For the coders to assign the codes. We're now in a day and age where coding drives reimbursement. Everything that you do in your healthcare practices is driven based on the codes that you assign. So if you're not assigning the appropriate codes, then you're potentially impacting the revenue that your practice is going to receive. So we have to make sure, again, that we ensure that the documentation is sufficient enough so that your coders can assign the codes that they need to ensure that you are properly reimbursed. Proper coding ensures that there are infrequent medical necessity errors. You also want to look at any charts to ensure that your doctors are signing charts, because again, all of those impact your revenue. Next slide, please. Okay, so I think we spoke about this already, so I'm going to skip ahead to the next slide. Okay, so the ICD-9 code system will be phased out in 5 months, and we've already looked at the 2 different code sets that will be used once it's phased out. We spoke about the fact that we have to ensure that you also have implemented version 5010 for your transactions. So all of these areas are extremely important in ensuring that you are ready for ICD-10 and that your revenue is not impacted. Next slide, please. Let's talk about how your claims are going to be handled. So as of October the 1st, if you're working in a setting that requires you to submit claims that span pre-October the 1st and go beyond October the 1st, you're going to have to split your claims into line item dates of services in order to ensure that your claims are appropriately processed and reimbursed. So if you have any claims that have a date span and you have dates of services that are through September the 30th, all of those claims should go on one, all of those services should go on one claim using your ICD-9 codes. If you have any services that require the use of, if you have any services that are after October the 1st, on or after October the 1st, then all of those services should be on another claim, and those should have your ICD-10 codes. So again, you want to make sure that when we're ready to go live with ICD-10, you're utilizing the appropriate code system to ensure that your claims are being processed by the payers. Next slide, please. I'm going to skip this slide because this speaks to our institutional facility. So next slide, please. So what will happen to your claims? So if you're submitting any claims on or after October the 1st, and they contain ICD-9 codes, I'm going to just address a question that was asked. When you say phase out, does this mean ICD-9 will still be available for a while, or is it really a cold turkey cutoff? Well, as of right now, it is going to be a cold turkey cutoff. So I'm going to answer your question now actually with this slide. So if on October the 1st, if you're seeing a patient and rendering any medical care on or after October the 1st, and you submit ICD-9 codes on those claims, your claims will be denied. So what's going to happen is going to be returned back to you as unprocessed, and that's why it's extremely important that you make sure that you are using the appropriate code set once we go live. For any services through September the 30th, continue to use ICD-9. For any services effective October the 1st, you have to begin using the ICD-10 code set. And that's the reason why if you have some services that are span dates, that you'll have to split the claim. So one claim will have all of your ICD-9 codes and services or dates through September the 30th. You'll have another claim that will begin on October the 1st and have all of the ICD-10 codes so that you can ensure that there is a smooth transition once we move into ICD-10. Next slide, please. So again, continue reporting ICD-9 codes on all of your claims through September the 30th. Anything after September the 30th, you must begin using ICD-10 or your claims will be denied. Again, the services that will not be affected in your practice, or rather I should say the code set that does not affect your code practices, are the ICD10 PCS codes, which were the procedure codes. And it looks like we have another question. What will happen if I submit a September 22nd, 2015 date of service on October 15? Okay, so if the date of service is September the 22nd, you have to use ICD-9. Any dates of services through September the 30th must contain an ICD-9 code. It doesn't matter when you submit the claim processing is based on the date of service. If the date of service is September the 22nd, the ICD-9 codes must be used. If the date of service is October the 22nd or October the 1st and after, then the code set that you have to use is ICD10CM. All right. So we are counting it down, and as of today, we are 125 days, 5 months, or rather I should say 125 days or 5 months away from the ICD-10 implementation. And I see another question. Will you be sending out a copy? Yes, it's my understanding that the PowerPoint and the resources that were prepared in for the presentation will be available immediately following the presentation. Yes?
Stacey? I just want to let everyone know that, because that question has come up several times, that we are recording the webinar and we will be archiving it and the presentation on our website as soon as it's available. Also, really quickly, if folks have any questions, if they can continue to type them in the Q&A box, and we do have some time allotted when Stacey's finished to answer those. That would be great. Thank you.
Okay. Next slide, please. So we're 5 months away, and the question on the floor, are we there yet? In order for you to be up and running and ready for ICD-10 implementation, there are a few processes or a few areas that you need to look at in your practice to ensure that you are up and running on October the 1st. So you will need to look at all of your processes that currently exist in your practice. You need to assess the people to ensure that the people are trained. And you will also need to access technology to make sure that your systems are fully remediated and fully up and running in preparation for ICD-10. All right, next slide, please. So I put together these few short steps, hopefully to get you to begin thinking, if you haven't already, about the things that you need to do in preparation for ICD-10 implementation. So the first step, you need to do a readiness assessment. Step 2, identify your team, your implementation team. Step 3, put together your budget. Step 4, identify your processes and your systems that use codes. Step 5 will be to identify the staff that need to be trained, as well as create a training plan, and also put the right people in place to train your staff. Step 6 is to test your systems and your processes. Contact your vendors and make sure that your vendors and your payers are ready. And the last step is sort of kind of like a continuous step. So even though it says step 8, this is something that you should continuously do, not just in preparation for ICD-10, but even after ICD-10 is implemented, you should continue to monitor to make sure that there is no impact on there's no negative impact on your revenue. So next slide, please. So the first thing you want to do is perform an initial assessment of your practice. You want to sit down and develop your overall project plan, and you'll need to get approval, obviously, because depending on how ready or how much time you need to get ready for your ICD-10 implementation, you'll need to get approval, because there will be some financial impact, and there will be some other areas that will need to get approval, prior approval from your higher-ups in your organization. You need to identify all of the areas and all of the business units that will be impacted by this change. So if you have, for example, a large practice, your front desk is going to be impacted, because the staff at the front desk, those are the staff that's responsible maybe for contacting the insurance companies to get authorization or to check eligibility. So those folks will be impacted. Your providers obviously will be impacted, because if a patient has one of the managed care insurance plans, they may require prior authorization. And it's been my experience that when you call to get prior authorization, they usually want to know the diagnosis codes, and they usually want to know the CPT codes. And so if you've not updated your systems to reflect ICD-10 codes, your prior authorization may not get approval because you're using the wrong code sets. All right. You also want to communicate the changes, how the changes are going to impact your organization as well as what changes you need to make. And this should be communicated to your executive level management team, because again, they ultimately will be responsible for ensuring and making sure that the resources is available or allocated for this this implementation. You need to also sit down and put together realistic time frames so that you will not impact the different processes that you currently have in place. With this particular project, it's not something that you want to just jump into. It's something that requires a lot of thought process, and you want to lay out your realistic timelines to ensure that once you are putting all of these pieces in place, you're able to roll this out on a high-level basis. You also want to identify tentative issues, because there will be issues in terms of how you're going to roll this out. And I think there's another question. How would you suggest monitoring readiness if there is no apparent test environment? Well, the good news is the payers that you contract with, a lot of them have been doing end-to-end testing. In fact, I know that, well, I think the deadline has passed. As a matter of fact, I'm sure the deadline has passed. CMS was requesting that providers participate in their end-to-end testing. That's coming up next month, and I think the cutoff date for that to be a part of that process was May the 22nd. But you can still contact your other payers to see if they will allow you to submit test claims to ensure that they are ready, to ensure that you're ready. And I think there's another question. Do you feel that there has been adequate test environment in general nationwide? My opinion is yes. And the reason why is, again, just in terms of all of the activities that CMS has been doing in preparation for the ICD-10 implementation. Each time when the implementation date was set, there was a period of testing that was also proposed. And so I know CMS is doing it. I know that the local state Medicaid agencies have also been doing it. There have been significant number of third-party commercial insurance plans that have also participated in these end-to-end testing. So if your practice has not had the opportunity to engage in any of these activities, you should follow up with the insurance plans that you participate in and find out if it's too late for you to engage that process. The next slide, please. Now there's another question. Can you describe how you would bill if you are treating a patient over a period of time and your encounters with that patient spans across October the 1st? So if you go back to, I don't remember the slide number. So again, in terms of a claim that spans pre and post implementation, services through September the 30th, 2015 have to be on a separate claim with ICD-9 codes, and all of your services for October the 1st and later have to be on its own separate claim with ICD-10 codes. So you will have to separate your claims because the systems, the way, at the present, when I started the presentation, I was speaking about the ICD-10 Act. That was one of the requests that the physician community wanted CMS to entertain. And at the time, at the present, they're not willing to do that because they're thinking that that might be problematic. And so right now the advice that has been given is that you have to split your claims. So all of your claims that have ICD-9 codes through September the 30th will be on separate claims, and all of your claims, all of your services that have ICD-10 codes will have to be on a separate claim. So you have to split the claims. You will not be able to submit a claim that contains ICD-9 and ICD-10 codes because the claim will be denied. All right. We were developing the plan, getting approval, setting up a regular reporting system. So again, you want to be able to set up a reporting system. You want to track that. You want to monitor and stay on top of that process to make sure that you are meeting your deliverable schedule, because it's important that if you find that there's a hiccup in your process, you will be able to address that hiccup and deal with that, as opposed to waiting until the last minute to find that something isn't working, or the process is not working for your facility, for your practice. Because remember, there are going to be hiccups in this process, but ensuring that you put the process in place and begin that process of thinking about ICD-10 and what you need to do to prepare for the implementation is the key to ensuring your readiness. All right. On the bottom of this slide, I provide an interactive online tool that CMS has created and has shared with the provider community. So take some time to visit CMS's website and visit the interactive readiness tool, and this will help you to gauge where you are at the present time. And so obviously, if you've not done anything in preparation for ICD-10, then you already have an idea of where you are. You have a lot of work ahead of you. If you've at least thought about ICD-10 and you've started some of the activities necessary to move forward with the implementation, you should be able to, do a check off to see what other activities you need to do in order to prepare for ICD-10. Next slide, please. So identifying your implementation team. So you want to coordinate the team members that you feel will be ideal for your ICD-10 implementation. You will need individuals that have a mix of talent and skills to be a part of that team. And so the first thing you want to ensure is that you have coders on your team. And ideally, they should be certified coders, because a certified coder will be able to help you troubleshoot the various coding issues that you will be faced with. You need individuals on your team with a strong IT background, because again, if you go back to the very beginning when we were speaking about the remediation from version 4010 to 5010, well, only someone who works in IT would know what that language is and what that means. But more importantly, it has to be someone with a strong healthcare IT background. So not everyone who's in IT would necessarily know what version 4010 and 5010 is. So it would need to be someone who has a strong healthcare IT background to assist you with those issues that you will have. They will help you with troubleshooting and things of that nature. Also, you want to have someone on your team that understands process improvement and business improvement. It's very important, because this implementation of the new codes is a very, very big undertaking. You need someone who's going to be responsible for project managing this implementation for you, so that it will be rolled, so whatever your processes is that you need to implement will be rolled out in phases in preparation for your ICD-10 implementation. Next slide, please. So the budget aspect is very important. You don't want to spend too much money, but at the same time, you don't want to not allocate sufficient enough money for the ICD-10 implementation. And it's not just about the ICD-10 implementation. It's about the resources you need for staffing, the resources you'll need if you have to remediate your software, the resources needed to purchase new coding books. Because the ICD-10 coding system is new, you'll need new books. You may need to bring in some experienced coding personnel. So these are going to be areas that your finance department will need to be involved in making sure that you budget appropriately for this ICD-10 implementation. And it's not just about spending money now, it's about thinking ahead for the future. Because again, because this project is such a huge undertaking, and because you only got 5 months remaining to begin that process, you want to make sure that you have that you've budgeted for at least 1 year or 2 years out, so that in case something happens when you go live, when you flip the switch to go live, you have a contingency plan. Next slide, please. So again, we spoke about the long-term impact of your revenue. So again, you want to make sure that you have sufficient enough, that you budgeted and allocated resources so that you will have a plan in place in the event that your ICD-10 rollout isn't on schedule. If you have to update your system versus replace your system entirely, you'll need specialized staff. You may want to do training on-site. You may want to do training off-site. You may want to bring someone in from outside to do your training. So all of these have to be budgeted and planned for to ensure that you are ready once you go live with ICD-10. Next slide, please. Identify your processes. So again, you want to do a full assessment of all of your current processes so that you can get an idea of everything that currently uses your ICD-9 codes. So your provider contracts. You know, I've worked in practices where the insurance plan includes diagnosis codes as well as CPT codes in the contract. So you want to make sure you look at your provider contract. You want to make sure that your systems that interface with one another are all remediated. All of these play a major role in ensuring that your ICD-10 implementation is successful. If you're currently using paper encounter forms or electronic encounter forms, most of the encounter forms have diagnosis codes on it, they have CPT codes on it, so you want to check those and make sure that your codes are updated. Your claims and your appeals processes. Some of the insurance payers have diagnoses codes and CPT codes as part of the appeals process. So again, you want to make sure that all of those have been reviewed and that your codes are updated. Patient statements, authorizations, and referrals, your eligibility processes. These are all areas that will need to be reviewed to determine if ICD-9 codes, or rather I should say the implementation of your ICD-10 codes will be impacted. Most of the insurance plans have already begun the process of changing their health plan coverage policies and their medical review policies and reimbursement policies with ICD-10 codes. So you will want to contact all of your payers and make sure that you have this information handy before the October 1st go-live date. Next slide, please. Creating a training plan. So again, you want to make sure that you prepare a training plan and that you track the results, because without a training plan, you won't be able to identify those individuals in your practice that need to be trained. To some extent, your providers will need to be trained. Your nursing staff will need to be trained. Your non-clinical staff who engage in processes such as verification, insurance verification and eligibility, those individuals will need to be trained. So you need to put together a training plan and identify those individuals that require training. You need to determine how many hours of training those individuals provide. It's not suggested that you put everyone together in the same session, because the level of training that's necessary for a coder versus a clinician is not the same. Next slide, please. So again, we were discussing who needs to be trained. So your administrative staff, billers, coders, doctors, your IT staff, your executive level staff, all of these individuals need some level of training, and in terms of your practice, because each individual practice needs will be different. So you have to determine your practice needs, your individual practice needs, and determine how much time is necessary for training. You need to determine if you want to totally outsource it, or if you're going to have someone come in to your practice and handle your training needs for you. Next slide, please. Very important information on CMS's website regarding training sessions. CMS, over the past 4 years to the present, have been providing a series of training sessions for healthcare providers, as well as the Medicaid state agencies that have been involved in this process. So you should follow up with CMS as well as your local Medicaid state agencies to find out what training opportunities are currently available. I know that there's one upcoming on June the 18th, but that one is specific to institutional providers. But there have been a series of training sessions that have been provided by CMS, by Medicaid state agencies, as well as the third-party insurance carriers. So follow up with all of your insurance carriers to find out what is available to you and take advantage of that. If you visit CMS's website, the link is here on the slide for you, www.roadto10.org. There are numerous training resources that are available to you on their website. So take advantage of that. If you're a member of any professional society, you want to take advantage of that. So if you are a provider and you are a member of the AMA, they have training resources available to you. If you're a coder and you want to engage in any coding training, you can follow up with the local professional coding organizations. You have AHIMA, you have AAPC. There are numerous professional societies out there that have joined forces with CMS to provide training materials and training information to providers and practices. Next slide, please. You have to test your systems to ensure that they are ready. You have to contact your vendors to make sure that they are ready. And so again, all HIPAA-covered entities must begin using ICD-10 for any services performed on or after October the 1st. And if you have any business associate agreements out there, if you are using a data warehouse or a clearinghouse, you have to make sure that all of those entities are currently ready for ICD-10. So you need to put together a checklist that will help you decide, to determine who's ready and who's not ready. Next slide, please. Health plans and state Medicaid agencies have already revised their policies. So again, you want to make sure that you reach out to those respective entities so that you can get this information, so that you have it beforehand before we move forward with the ICD-10 implementation. Again, in terms of the folks that are on the phone that have a high volume of patients that are Medicaid managed care or Medicare managed care, because they've already remediated their systems and updated all of their reimbursement policies and medical review policies, you want to contact those entities and get that information so that you are already apprised of the changes that they've implemented. Next slide, please. You want to contact your vendors and make sure that they're ready. You want to also confirm that they are HIPAA transaction 5010 ready. How does your practice use the codes in comparison to how they use the codes? When I worked for one of the health plans, they were very liberal with the how their participating providers submitted claims. And what I mean by that is, even though CMS requires that all claims have diagnosis codes assigned to the highest level, this particular health plan that I participated in did not require that. So, for example, the diagnosis code for diabetes requires 5 digits in order for the code to be considered correct. Well, this particular health plan did not require that. So as long as you had the 250 on your claim, which is the 3-digit category for diabetes, they accepted the claim. But in ICD-10, you have to use the codes. They have to be assigned to the highest level of specificity, and it has to have all of its applicable characters. And so you want to make sure that your vendors have already updated their systems so that when you submit your claims to your clearinghouse, and then the clearinghouse goes to submit the claims to the insurance carrier, that the claims flow through all of the processes and that there are no denials or rejections as a result of one system not interfacing appropriately. Next slide, please. Everybody's going to be impacted by this change. Doctors, hospitals, patients, everyone's going to be impacted. So it's important to make sure that you are at least thinking about what you as a practice need to do to ensure that you're ready and that you reach out to all of your trading partners and all of the entities that you do business with that may have an impact on coding to make sure that they're ready as well. Next slide, please. Make sure that your vendors understand that ICD-10 readiness is important to you, and there might be an issue with time frames. Your time frames may be different from your payer time frames or from your vendor time frames, and so you may have to make changes in one of your contracts with one of your vendors if their time frame is not consistent with yours. So you want to make sure that there's a discussion, that you at least open the floor to ensure that your vendors have done their part in ensuring that they're ready for ICD-10. All right, next slide, please. Very important that you make sure that you perform testing with all of your vendors. So by vendor, that's not just the health plans that you participate in. It's going to be any of your third-party entities that may be doing business on your behalf. That is critical to your success. You want to make sure that everyone is fully ready when ICD-10 is implemented on October the 1st. And the only way to do that is to start doing testing, one-to-one testing with your payers, with your vendors. All of this needs to be done beforehand. So in terms of ensuring readiness, you want to put a schedule in place with all of your vendors, and this schedule should be so that they submit information to you before October the 1st. You don't want that information to be processed on October the 1st, because then you will not have sufficient enough time to catch any glitches or any errors that may impact your claims processing. Next slide, please. Delays. Again, just because we are running out of time, we only have 5 months left. We want to ensure that if there are any delays, that you adjust your implementation schedule to account for them. Everyone's working on a different time frame, so you may have to change vendors, or you may have to change the process to account for a delay or some unforeseen incident that may occur. Next slide, please. Continuous monitoring. So again, it's very important that you don't just monitor because we're moving to ICD-10 and then you stop the process afterwards. You want to continue to do this monitoring process. Once you've accumulated enough data from all of your vendors, you want to go back and do a comparison to look at a snapshot in time, pick maybe 30 days, maybe 60 days. You want to look at the data for ICD-9 compared to your data in ICD-10 to see if you notice a dip or an increase, and then you'll be able to go back and reevaluate your process and make whatever changes are necessary to ensure that you fix whatever the discrepancy or the issue is. So in terms of continuous monitoring, you want to implement a process or a plan where you go back and review or on counter forms, you want to go back and review your claims. You want to make sure you go through a process where there's continuous monitoring of all of your processes during this implementation. Next slide, please.
Stacey, this is Julio.
Okay.
I just want to let you know we're running almost 15 minutes or over, and we still have a couple of questions.
Oh, okay. So then why don't we go skip to the slide that says next step. All right, so next steps. Here's just a few tidbits of information that you can use that I thought would be extremely helpful for your ICD-10 implementation and what you need to be thinking about, what you should be doing in preparation for ICD-10. This information is also available in the resources that were prepared for you in the presentation. The first step is go to CMS's website, maybe do the interactive transition and timeline to see where you are with your practice. Reach out to some entities that will provide you with assistance and support after you've had an opportunity to look at some of the resources that are on CMS's web portal. Next slide. So you should sign up for CMS updates. They'll send you regular updates to keep you in the loop. Next slide, please. Here are the web resources that were used to prepare the presentation. So the web resources are on the next few slides. There is one resource that I used just to put together the PCS portion. And I would like to thank everyone for taking the time to join the presentation, and I'm going to turn it back over to Julio now.
Thank you so much, Stacey. I just wanted to address, we did have two questions, and I will give them to you before we sign off. The first was, can you clarify the difference between ICD codes and CPT codes?
Okay, so for those of you that did not have the opportunity to join us last year, we did a very high-level, Health HIV did a high-level presentation on the ICD-9 codes and the CPT codes. The ICD-9 codes are two code sets. The most integral portion of the code set are the diagnoses. The diagnoses describe the medical conditions. So, for example, a patient has diabetes. You have to go to the code books in ICD-9 and translate the diabetes to a numeric code. And your CPT codes describe the procedure or the services that were provided to treat the diabetes. So, for example, for a patient that has diabetes that goes to their primary care physician, the evaluation and management code would be used to assign a code that describes the level of care that's provided. If the patient needs if the physician at that visit decides to do a hemoglobin A1C test, the code for the A1C test is also assigned from the CPT code book. So the CPT codes describe the procedure or the service that was performed to treat the medical condition, and the diagnosis codes describe the medical condition. So now your ICD-10CM would be the diagnosis codes, the ICD-10PCS, which you will not be using, that's only for facilities, will also, they also describe procedures.
And then, thank you. The second question is, will health departments use ICD-10-PCS?
The health department will use ICD-10 PCS, but those will only be used for institutional providers. So institutional providers will have to submit ICD-10 CM codes and ICD-10 PCS codes. So your institutional providers are your hospitals, your nursing homes, you know, those institutional providers. Private practice doesn't count as an institutional provider. The private practice settings will use ICD-10CM and the professional providers, which are your clinics, you have your private practice providers, they will use ICD-10CM, PT codes, and some of them will also use HCPCS codes.
Okay. Thank you very much, Stacey, for your very informative presentation. As we've stated, we will make the presentation and the resources available on our website, as well as upload the recording of this webinar once it is archived. I will send out an email to everyone. We have everyone's email that had registered to participate to get that information out once it's all in place. I know that there are